It's just 13 of us, that's all. I'm going to start saying hello and welcome to everybody. The crew is slowly joining in. It's lovely to see each other again for another year of COBRA rounds. I think this was such an emotional program that Prithvi's late. I think he has to get himself mentally kind of prepared for this because, just needs to psych himself up. So my colleague and friend, Prithvi Mithranjaya from Stanford, is this how it rolls at Stanford? Are you guys like late to everything? Or is this what the PD does?
It's the West Coast, man. Come on.
West Coast vibes.
Ted, you're on time to everything, bro. I mean, I've done a number of programs.
I grew up on the East Coast.
He's from New Jersey.
Yeah, I'm East Coast.
I got you. All right, so we're gonna say it's the West Coast vibe. Yeah, Prithvi grew up in Rochester, so that is Rochester, New York. So that's very, 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 very East Coast.
It's the western part of New York.
That's true. Welcome everyone to COBRA Year 2. It's lovely to have everyone join us. This is kind of a grant video case series for surgical retina fellows and obviously anyone else who wants to join. We have an incredible crew of people who are joining us tonight and some fantastic fellow presentations. And it's led by faculty over at the Cole Eye Institute, my colleagues Kat Talcott and Sumit Sharma, and faculty at the Byers Eye Institute, normally Prithvi Mithranjaya, just imagine another balding Indian guy over here. And then Steve Stanislaw, Ted Lang, and Carolyn Pan, I think, is also with us as well. So thanks everyone for coming in and joining. And I want to first thank Bausch and Lam for their support for Year 2. I know I have Rob Nemitz from Bausch, I'm going to give him the floor for 30 seconds to say his piece, and then we'll get started with the program.
Yes, Neil, thank you. Don't have a lot to say. Just appreciate all the participants, the faculty. What you came to me with this kind of idea a couple of years ago. I looked at you sideways, and we decided to go ahead and do it and kick this thing off. And how much fun it's been to see it be such an engaging educational event that's just grown over time. And I think the participation we got is far exceeded what we ever expected. From the B&L side, my ask is relatively simple. If you're working with us, awesome, truly appreciate it. If you're not, just consider us. We have some great people who are out there and want to support you. We have a really strong platform in Stellaris Elite, and we have some really strong accessories that we've developed and acquired over the years through Synergetics, instruments, laser probes, all sorts of different things to help support you in your procedures. And if you have time, pay us a visit at the Academy. We'll have some new stuff at the booth, some exciting things. We'll also have a wet lab there for you to play with all the pieces and parts. So without further ado, I'll let you guys kick off the program, but thank you so much for the time and allowing us to be a part of this. It's been fantastic.
Thanks, Rob, and thanks for those words. And speaking of Academy, we are also excited to announce that we're going to be doing this program live at Academy. Well, we'll have some details here at the end, but it's going to be on Friday night at Academy, September 30th. A really cool space on the rooftop at the Witt Hotel. We'll have our fellows present. We'll have our faculty in person. We might even have a couple of things of food and drink just for some of us to make sure we're enjoying ourselves too much. All right, so let's get started. The theme for this this first COBRA panel. Hey, Prithvi.
Hey.
Show up. Hey, welcome. Did you
Thank you
did you have
much.
to go buy that shirt? Is that what you were going to do?
I did. I combed my hair for this. We're ready to go.
All right, so Prithvi, we're just talking about the theme for this first COBRA are things that I've learned for the first 2 months of either your first year or your second year. Can you believe that you actually got some fellows to come to your program this year? I was impressed.
I know it's I guess bribery goes a long way. It's a good thing, and I think you came up with this theme, and it's a good one because the first few months of fellowship, you learn a lot. And I always say that in the second year, also, you seem to forget everything at a certain point, like right about now, like after about 2 months into second year, like everything that you're flying with, suddenly it feels like it's tanking. So, you know, kind of remembering what it was like and how far you've come probably will help you to, you know, get over that hump that we all remember having when we were fellows. So I think the greatest, you know, growth period is probably that first 2 months when you start, you know, transitioning from resident to fellow. So these should be good ones. So Sunil, this is going to be highly critical. We're putting down fellows today. We're like breaking them down tiers.
So this is a new year of COBRA. The gloves come
COBRA
off.
2.
Fangs, the COBRA, the head of the snake come out, especially from our faculty. We have a really rough and tumble faculty. So how about we get started with Leanne Clevenger from over here at Byers Eye Institute. Leanne's one of our superstar first years, and I believe Kat Talcott's gonna be our faculty engagement person or liaison or coach or emotional support, emotional support attendant.
I just want to clarify, am I making her cry or am I supporting her after you guys make her cry?
Whatever you want.
Which way are we going here?
Whatever you want.
We'll see. We'll see how it goes. Thanks, Dr. Shrivastava. Nice to see everybody. I'm going to show you a lot that I learned in actually 1 hour with my very first Acreos lens. So let me see if I can share my screen here. Can you guys see this video?
Yes, looks good.
Yeah.
Awesome. All right. So I did this case with Dr. Yuan, who's one of our staff attendings here at Cole. So this patient, just as a background, he'd already had a complicated cataract surgery with actually like a black lens that had been dropped, already has undergone a vitrectomy. He's actually aphakic. So really, this is just a straightforward sutured lens case. So I'm starting off here just with the peritomy. And now we're marking 3 millimeters back and then 4 millimeters across on both sides.
Leanne, just take a step back. Can you talk us through about what the thought was for putting an AO60 in this patient versus another type of secondary lens?
Yeah, I think at the hospital that we do these surgeries, I don't know that we have the Invista lens, but I know we typically use the Acreos, that we like the 4-point fixation over there. That's just what I'm familiar with, but I know you tend to use some of the Invista lenses at Cole. Can you guys hear me?
Yeah, no, we can. So I was gonna say that.
Okay.
So Kat, if you had your pick a lens, maybe that's the way I'd ask it. Leanne, would you pick the AO60 in this case? See, Kat was trying to be nice. I'm going to be the mean one.
I'm not good at making people cry, except if they're my kids.
I think so. There's a little bit of concern that he already had some like corneal edema going on. So we're, a question I had asked was like if this lens, we were worried about it ever like having haze across it at any point, if he needed a secondary surgery with gas. But we chose to go with the AO60 anyways, and so far so good. We're almost a month out with him.
Well, now you spoiled it. Now we know it goes well.
Yeah.
But,
yeah.
So
but
you were
I think
saying
just to
that
keep in mind there. Sorry, go ahead, Sunil.
No, go ahead. Go ahead.
No, I'm just trying to make the point that there's tons of options for lenses,
Yes.
like there's sclerosutured lenses, there's Humani lenses, there's ACIOLs, and some of it is like stylistic. It depends on where you're at and who you're doing it with and what their sort of, preferred sort of lens to go to is. But I think it's just good to keep in mind that there's a lot of options.
Contact lenses.
Contact lenses, yes.
Hey, so Leanne, let me ask you this. This was your first AO60, right? This is your first sutured
Yes,
IOL?
my first one. Yes.
Okay,
Yep.
so can you walk me through how you mentally, and it sounds like I'm being a little hokey here, but how did you get ready for this? Like, tell us like what you did. Like, obviously you probably a little, not that you have nerves of steel, you're a phenomenal surgeon, but like, tell me, how'd you get ready for it?
I think that for me, like watching videos is the most helpful, but it seems like there's a lot of variation for actually how, like technically how it's done. So that was a little confusing to kind of go through to watch all those different techniques and its small variations. And we'll kind of get to that, I guess, as we're going through like how people orient the sutures or how we fold the lens, and just kind of realizing that, at least to be methodical about it and that it can, to be organized, I guess was the biggest thing.
Yeah, I think that's a good point. I mean, I think that, every attending has different preferences for how they do cases, but for these cases, I think there's a lot of individual decisions that people make and do it a little differently. And, I think these are cases that as a fellow, you haven't really seen often before if you're a first year fellow. And so it can be confusing to just go into the case and expect that your attending is going to walk you through it. So I think that I found that actually watching videos when I was a fellow was like really helpful for sort of remembering the different steps. And I think it's really important in general to like have a powwow with your attending beforehand and be like, what are your preferences? How do you like to mark the cornea? Like, where do you like to put your ports? And all those details so that, as a fellow, you're able to sort of stay in the surgeon's chair for longer after they trust you a little bit more.
Agree.
All right, you got through one trocar cannula.
Not even. We're not even through. We're almost.
It's almost there. It's almost there.
So Dr. Yuan likes to do just the 2 cannulas and then 2 sclerotomies inferiorly, and this is a left eye for the patient. So doing the nasal side now. And then orienting the kind of the blade parallel to the limbus as we're going through was important. We're just looking around again. He'd already had a vitrectomy, so we're making sure there's no pathology. We really didn't see anything going on. So this is our my clear corneal wound, and I think that I struggled with this when I was first doing it. We wanted to make it 4 millimeters, and I was so focused on tunneling and making it a good wound that it ends up pretty short, and my attending is helpful to show me that it's very short, to extend it and make the internal opening kind of wider even than the external opening to about 3 to 4 millimeters. He's showing me maybe a little bit more, so we're making it wide and nice.
Carolyn had a great question that she put in the chat that I think is an important point to talk about, and also sort of aligned along the preparation is, can you tell us, Leanne, a little bit about, I don't know if you looked at the lens calculations for this patient, but sort of how did you decide sort of what power of the AO60 to use? Are there any sort of considerations that you take into account as you transition from being like a cataract surgeon as a resident to sort of a retina surgeon?
Yeah, this patient actually was a very high myope, and I have the box in a minute, but he's ended up with like a +5 acrio. So we wanted to, for him especially being so highly myopic, to aim even more minus than usual. So I think we went to like -1, -1.5, and actually went with a similar power to just a little bit more minus than like what the in the bag power was, just based off of where the kind of the lens position sits.
Mm-hmm. Yeah, I think there was a really good study that came out of Wills, I think a couple of years ago, that sort of looked at for sutured lenses, sort of where the planned target was and where they end up. And a lot of these patients end up being like more like myopic than you expect. So sort of like traditionally, like a lot of people for cataract surgery will aim like -0.5, but I've learned over time to do just shy of plano for these people to get them sort of so that they don't end up like more like myopic than like you anticipate. But I think it depends a little bit on how far you're putting your trocars back from the limbus as well. I don't know if anyone else does anything different when they interpret their IOL calculations for these cases.
Steve, how do you manage that?
Well, I usually put him 2.5 millimeters back instead of 3 typically, unless it's a really, really long eye or like a Marfan's patient or something. And I do go pretty close to plano. I usually go for like a -0.25, and that way if I get a little more myopic, I'm okay. I don't think I've ended up hyperopic on these so far. And I tell the patients during the pre-op visit that we're not going to be as accurate as you are going to be with regular cataract surgery. This isn't, we're not refractive surgeons here. We're trying to get your best corrected visual acuity, and if you need glasses, that's part of how it goes, because we just can't be as accurate with where we're placing the lens as the cataract docs are.
Just don't have a fluoropter in the office. It solves the problem.
Hey guys,
Right.
quick comment too for some of you out there. This is Hassan. I'm not on video, but always double check if these patients have had previous refractive surgery. That's a big area of potential slip up, and I have never hesitated to utilize my cataract colleagues to help them like confirm lens calcs in these types of cases, because they can be quite tricky. And again, some of these cases, these things went south with a premium lens in the eye even, and you got to reassure that patient that they're not going to get that perfect outcome. But if you can come as close to getting them to plano, then that's your best bet. But always inquire about previous refractive surgery.
I think that's a really great point, and it's becoming much more evident as we see this the generation of our patients who who had refractive surgery are kind of come into this day and age of getting older and having their lens. And so, I'm getting more topographies and walking over to my cornea specialist to help me out for some of these.
Can you guys talk about whether 25 or 27 gauge you guys typically do for these AO60 cases? And
yeah, well, let's pull it. So, Kat, what do you do?
I'm 25. I use some 25 gauge or 27 gauge max grips for some of the parts, but I'm 25 overall. How about the rest of you guys?
I'm a 25. I think Leanne's going to show it. I like the 25 gauge, the Bausch angled, sorry, IOL forceps, because I think they work really, really well for these. So I tend to be 25 for these.
I'm 25 too, but I don't use 27 for much of anything actually. So I'm just used to 25. I like it. I think you could certainly do it with 27 if you're using 27 gauge forceps to go through the incision. The one part that might be a little harder is burying your knot. I tend to actually push the knot in anyhow rather than pull it to bury it. So I suppose you could still do that through a 27, but that would be a little bit more difficult. And I try not to have any tension on that on that whole suture if I can avoid it, because I don't want to cheese wire through any haptics and things like that. But so I like 25. I think it works well, and I haven't had hypotony or problems with leaks.
Asan pointed out that he had published on this.
Go ahead, Fitzy.
Yeah, Asan made a note that they had published on this with 27, but he's not. It doesn't sound like you're only using 27, Asan. You're good with 25.
I mean, this back when I was second year fellow at Wills. We did a lot of these acreoses then. Ali was my junior fellow, and that was right when 27 was coming out. So that was like the first thing, you come up with these ideas. Oh, 27 is going to be great for these cases. We did it. Ali was the first author on that. Published a nice series. Great outcomes. No issues with hypotony. But again, in real practice, I haven't seen any issues with hypotony with 25 anyway. So I don't see the utility for 27.
I would say for your first cases doing this, you have a little bit of flexibility and movability with the 25 versus trying to get thread that needle with the 27. So you can get there if you want, but when you're starting, I think 25 sounds good.
Go for it, Leanne. We're gonna let you. Yeah. We're gonna let you actually get through your case.
At this rate, she'll never finish.
Maybe. All good.
All right. Let's remember. We want the fellow to talk.
So I think, to back up a little bit, we also wanted to make sure we oriented the lens correctly. And another thing that I've seen is that a lot of people have different kind of methods for making sure they have the lens oriented. So one thing I heard was to actually make sure that this kidney bean shape, if you're looking at the patient, that it's up to the top right. I've also heard something about it being to the left shoulder, but I'm not really sure what that is. If anybody uses that, please let me know. I was still a little unclear. And then also it's vaulted kind of posteriorly, so making sure that's pointing to the back of the eye seemed like almost the easiest way to do it. So just flip the lens and kind of look and make sure that the vault is pointing behind.
Until you've done a lot of these, I think just look at the box, ask the nurse to show you the box, and if you put it in, how it's, if you're looking at it and it looks the same as the box, then you're okay.
So the left shoulder is if you orient it on the cornea, on the eye, that eyelet that should be pointing to the left shoulder of the patient. So if you orient it on the eye, like in your surgeon view, the left shoulder of that eyelet, it should be pointing to the left shoulder.
I've listened to you explain this so many times, Sunil, and yet every time it just goes in and it just leaves right away. And I'm left with, it's an aspheric lens. It's an aspheric lens.
Yeah, guys.
Come on, Kat. Yeah, go ahead.
Just a tip for the fellows, because again, I've reoriented. I've told myself so many ways to make it sense, and I always forget. Take a picture of the insert in the lens, that little fold out. If you're a fellow, just look at it. Remind yourself before a case, just look at it, and then you just kind of have the orientation right. This is tough to remember otherwise.
I just have the nurse bring me the box. I just say, show me the box.
Show me the box.
Yep. Show me the box. All right,
Show me the box.
Tell me how you're doing this part.
Okay. I would say that this is a learning point for me with this case, because this is the first one that I'm feeding myself is infranasal here. And these are those forceps that you were talking about. The curve, I think pyramid handle Bausch and Lomb forceps here that are really nice, but I think my mistake going into this one was not rotating my McPherson around so that I didn't like indent the cornea as much as I was going in. So I think I found like, and I'll show you as we went into the eye, that it actually kind of blurred my view a lot because I just kind of tried to force it without rotating my hand around. And then I think another point that was made was actually how to orient my forceps so that I knew that I was onto the suture, even if I couldn't necessarily see it, but just kind of by tactile, like being underneath, was a point that was made to kind of make sure I was able to grab it. So we're now just kind of making sure everything is out of the way, organized again when we go in for the second one. And not to get tangled. And then again, turning my hand a little bit more with this one, trying to maintain that clear view. And
nice, not tangled. Good job. You're on a roll.
No spaghetti.
One
No spaghetti.
tip
far,
for like
so
for handshaking or docking is also to
Yeah.
take your forcep and bring it out through the corneal wound, actually, or close to the entrance of the wound, and then you have less of a entrance
Like in-
with your suture hand.
like you're saying, go farther with the forcep instead of with the
Mhm.
McPherson. Okay.
Yeah.
That's nice.
If you're using a 30 gauge thin wall needle for the Yamane, you can actually push the iris aside with the needle and come out the corneal incision itself, and then dock your needle that way, or your haptic
Nice.
that way.
Thank you. Yeah, so now just making sure that we don't get tangled, pulling, the assistant's pulling the sutures off to the side for me. Shout out Dr. Yuan.
You're making this look so easy and smooth. The third year, there's a bunch of third year residents, I think, that are watching this going, holy.
So kind of dunking
I'll
it
tell
in
you,
there, making sure we get all the way back.
your other suture is making me nervous. Thank you. Pull it. Thanks.
Yeah.
Thank you very much.
I
So
know.
happy you did that. Thank you so much.
Yeah.
Right.
I think that's a big teaching point. It's really like for lens cases, you need to be like really meticulous about it. Like I think you need to sort of be a little OCD about all the steps, because if you're not, then you can get things tangled. And once things get tangled, it gets really confusing really fast. But if you sort of do things in a systematic way and make sure, especially after you've done the one side, to keep those sutures sort of tight, it makes your life a lot easier.
So Leanne, this is going to be like the greatest teaching pearls you're going to give us, because you're going to tie these things now. So give us the magic. How did you tie these, and what was your gauge on how tight to make them? Because your pupil is not huge right now. It's not like you can see it clearly centered. So what did you do when you were trying to throw your knots, and what was the advice?
I think the first thing I did, which already happened here, is just make sure they were already, there was no like looseness within the eye already. So kind of pulling them all the way out, extending them off to the side so that I know that I didn't have a lot of slack already inside the eye. And then when I tied it, I don't, completely tie it on one side until I do the 3, and then I'll switch to the other side and do that, and not completely tie it down or pull it too tightly until I check inside to make sure that the lens is actually centered. I'm using a Kugling to kind of push the iris a little bit to look at the edges of the optic. So I think like for me, it was, not cranking down on it, I think was the advice. So just to kind of loosely, to flush to the sclera, but not necessarily like indenting it.
I think those are really good teaching points. I mean, I feel like it's a transition when you start doing these cases, because our intuition from like being residents is to tie sutures like as tight as you can. And you actually really don't want to make these that tight. If you tie them really tight, you could actually sort of pull through the IOL. So you want them to actually be, I try and think consciously about making them looser than I sort of want to, because you will inevitably sort of get it sort of tighter. But I really like your approach of doing 3 on either side and making sure it's pretty centered. The AO60 is like pretty forgiving for being sort of centered. But I think that's a nice technique. I usually trim my sutures on either side before I start tying, because otherwise the Gore-Tex is really long and you can get tangled up in it without realizing it.
This is a good step here. What did you just do there, Leanne?
So
What were you
I
looking for?
checked again. So I mean, we tied the 3 on both sides and then made sure it was centered. And then after I tied the first knot on the temporal side, then I checked again, make sure it was still centered, and then going forward with tying the other side.
So one of the nice things about the Gore-Tex is that you could actually tie your first throws and then your locking throw, and then you can check it. And if it's not good, you can actually meticulously untie the second knot, and you could go ahead and retie if you need to. As long as you haven't done the third knot, you can redo it, because you can't do that with like any other suture. But the Gore-Tex, because it's kind of spongy, you can still pull it open.
I think that was like a point that my attending made also, was not like it because of the texture of the suture, it doesn't require that you kind of crank down on it so much. Like it will hold with just like a nice tie, but not necessarily like pulling too hard. So now we're just rotating the knots into the eye, and the point made was to rotate it and then pull it back so that the knot's actually buried within the sclerotomy on both sides. This one was a little tougher to get in, so we used the forceps to kind of tuck it. And then we checked, well, I tied or sutured my cornea here, but we wanted to, after this, make sure that the sclerotomies were not leaking. And we found that this one actually was a little bit leakier than we wanted. So we decided to suture it. And this one was a little short. So you'll see that I tie it down and it's still not as, I think I was a little bit too timid, a little scared to go close to the Gore-Tex. And not long
can you
enough,
tell us
so.
about what suture is that you're using there?
Yeah, it's a sevenovicral suture, just to make sure that we can tighten up on the sclerotomy a little bit there.
Leanne, this is expert level stuff. So really impressive. So to the theme, tell us one thing you learned at the by the end of this case that you didn't know before that you've learned going forward now. One pearl, one magic piece of information
that everyone's going to take home and write down on their board.
I think there are a lot of points.
You get one.
I think the biggest was just like not overdoing anything really in this like procedure, like not like being very, very, very delicate. I know that's like pretty broad in general, but it really kind of just applied to like every step. Like it was like, just do less of everything that you're doing and it will go more smoothly. And especially like with the knot tying that we already kind of talked about.
Well done.
Don't lose track. Yeah, well done. Don't lose track of your sutures, and you didn't. So that was very good. So thank you, Leanne. We'll move on to our next presenter, who will also be sharing with us a case involving a lens. So our next presenter is Austin Knapp. Austin's one of our first-year fellows here at Stanford, who came to us via the Cleveland Clinic, where she was a resident, and we're very happy that she is now in the warmer part of the country rather than Cleveland, which is perfect right now this time of year.
Prithvi, could I interrupt before we go into Austin's talk?
Yeah.
Could I make just a slight little plea to Bausch & Lomb, since they're the sponsors here? If there's any way you can,
I know where this is going.
Acryos type profile lens with your whatever, hydrophobic polymer that you use for your regular lenses, we would all in the retina community love you for that. I bet if we cued this audience, who would use that lens every single time for every single secondary IOL case, and all of us are going to say yes, because we all love the Acryos profile, and the only reason any of us don't use it is because of the issue with hydrophilic. Which hasn't usually been much of an issue, but if someone's going to have a dissect, I don't feel comfortable using it. But so I don't know what, Rob, you can say about that. But,
it's a great ask. I'm looking at Sunil. He's made this ask more than once in a variety of different situations. It's something we're definitely interested in. I mean, there is obviously a better lens out here to support these cases. We're watching the prevalence of these cases go up. I know you're feeling it. Patients are aging. This is happening more often. You need a better tool. We want to be in a position where we're giving you a better tool for these cases. The part of this we've really struggled with is determining what the market opportunity is. At the end of the day, I have to make a really, really strong business case. If we could get some information just inside of this group, getting an idea of how many of these you are seeing a year, in where we think it's been going over the last 5 years, we can take it back inside and we can look for something here. We'd love to have something unique like this to help you. The numbers just have to make sense to get it funded.
Do you think
Leanne
we
is
could do
actually
something
doing a
through
research study
ASRS
of
or
our
something?
secondary IOLs. Yeah.
Oh, that's great. Leanne, honestly, I'd love to talk after this. We're looking for unique things, both for our IOL portfolio, but also in the retina space that we want to invest in right now. We just spun out of Bosch Health. We want to go make big investments in the space. So we'd love to talk about this more.
Yeah, awesome. Thank you.
Thanks,
We
Rob.
we have two mentors on this case, Steve Sanislow from Stanford and Ted Lang, who is here as well. So Austin, take it away.
Awesome. Thank you so much for having me. Thank you, Dr. Clevenger, formerly my chief, for that awesome case. I'll share my screen here. Maybe. 1 second.
I know in California the Wi-Fi doesn't work as well. I get it. It's just like,
Yeah,
especially
it's so
Stanford.
expensive.
It doesn't.
I may have to take a timeout. I'm not sure why it's not working. It could be my 10-year-old laptop, but I'm not sure.
Why don't we, Austin, as you are working through it, maybe if you want to email it to any one of us or the IBIS team, we can
I should
upload
have
it.
it. Do you want me to pull it up?
Why don't we,
Steve.
Hung-Ween,
I
if
have
you're
it.
ready. Okay, if you got it, then let's do that. Otherwise, we
Let
can
me
have
just
Hung-Ween go.
download it, and see if I can start it.
Why
Okay.
don't you talk through the case, Austin? Give us the history.
Yeah, I can, because I had like 4 slides, but they're not important. We can just show the video. But this is a 46-year-old guy. Kind of fits well with what Leanne just showed us. Who's coming for worsening vision in his right eye. He has a significant ocular history of a penetrating trauma with a screwdriver when he was a kid in this right eye. So he has a subsequent subluxated traumatic cataract, as well as iridodialysis and some zonular dehiscence. And he also is a high myope with an axial length of 30.82 in this eye. So he initially presented to the anterior segment crew, and this was sort of a combined case with them. So they sort of ran the show. His vision was 20/80 when he presented, I believe, but previously he was as good as 20/30. So the thought was maybe the lens is shifting, etc. He's kind of becoming intolerant of his contact lenses. So he wanted to have a surgical intervention at this point. So the thought was, but I'm not going to be able to pause it and such.
I can pause it. Just tell me when.
Just
Yeah,
let me know
perfect.
when to
You can
it,
pause
okay.
it right. Yeah, you can
Yeah.
pause it right here. So you can see that, we're sitting superiorly, so this is his right eye. So you can see, he has that trauma inferiorly and pretty much like maybe 180 degrees of zonular loss inferiorly, and, the superior subluxation of a pretty dense lens. So, we saw this under the scope, and the anterior segment folks were kind of hopeful that they'd be able to do a phaco and CPR, but that wasn't the case. So if you want to pause here really quick, sorry. So I just wanted to point out that one of the first things, that I learned from this case, or maybe the most important thing, if you're going to ask me it at the end, I'll just start with it, is that, measure twice, cut once. So really thinking through the different possibilities, especially in this case, because we weren't sure exactly what we were going to do, but we sort of had all the different scenarios kind of played out in our mind before we went in. And so this sort of guided even our sort of routine early steps of what we might do. And something else that I, learned is we have so many instruments, like we've already discussed, that are possible. And not all these instruments are compatible with different gauges and different systems. So it's also important to think about what you might need and what would be sort of the best setup to use those tools. So we were thinking we might need to use the fragmentome. And so for that reason, we use the 23 gauge system here, as you can see. And then for our supratemporal trocar, we're gonna go in not beveled, and we're gonna go in horizontally, just in case, we have to break out the frag later on. So that's already, you can play it here, sort of a difference. And that's why we made that conch cut down there to start. So the anterior segment folks played around for about 5 minutes and said, no way. So then we took back over and we're gonna put in our infusion line and make sure we visualize it internally. And that will come into play here because you'll see as I start to do an anterior vitrectomy under direct visualization, the eye is becoming very soft. And this is when the attending is kind of, freaking out. You told me you saw it, where is it? And if you want to pause it here, maybe this is another sort of important point that I've learned in the beginning of fellowship is always respect the infusion line. It's really, really maybe one of the most critical steps of the surgery because this is where we can actually do a lot of harm if it's not in the right place or in the right, in the posterior chamber. And so as you saw, we needed to troubleshoot this in real time. We're not sure why our eye is getting soft. We increase the infusion and it's the infusion pressure and it's still not going. Yeah, you can play Dr. Stanislaw. And so we wanted to make sure the line itself was running and you can see that it is here. And so we're going to put it in one of our different cannulas to see if that, works. And then we're also going to clear our infusion cannula and put it back. And hopefully that does the trick. And it does. So our theory is, there's a lot of visco that was put in before this. So maybe it was clogged with visco or most likely vitreous. So either way, I'm trying to now use the protractor to get as much of the lens as I can, but it was really dense. So we knew we weren't going to be able to get the whole thing. So then at this point, we turned to the vitrectomy part of it and we just tried to get as much as we could.
Hey, Austin, did you
yeah.
Did you specifically skewer the lens with the trocar or use an MBR
you can pause
when you went
here.
in?
Oh, you can pause it here, Dr. Campbell. So we didn't yet because we were still hopeful we may be able to get it with the cutter, but it was very evident as soon as I started cutting that was not going to happen. And so here we go in. Actually, you can play it. Here we go in with the MBR to enlarge our sclerotomy, but that's a good point. It's something I didn't do here that probably would have been really helpful because as you'll see, it was just really hard to get with the frag. I saved you guys a lot of pain that Dr. Lang sat through of me trying to eat this delicately. And at this point, you can see I skewered it a lot in the back, but it was just so dense. It popping on the frag, and so here it eventually goes bye-bye. So, but I think that would have been super helpful if we would have done that and tried to break it up a little bit more in the anterior segment.
I think that's a really good point. I think there's different approaches that you can take. You can try and struggle with like the 23 gauge cutter for a while versus sort of cutting over. I generally like to try and get what I can with the 23 when it's like in the correct position. And then if it's not, I kind of just push it to the back and like to use the frag back there. Because the thing is with the frag, there's surges that you can't see. And I'd rather have good visualization when I'm doing that with the retina.
So I think you didn't talk about, preoperatively planning other than that you were prepared to do the frag. I mean, I think some key things are, age of the patient, what the density of the lens looks like, what you can see, because if this lens looks pretty dense, it's pretty brown. So I think you're not going to likely be able, you could get it with the cutter if you want to be there for 3 hours, but your attending is going to get really upset if you just sit there trying to chip away at this with even a 23 gauge cutter. So in a case like this, you should be prepared to have the frag right away, which it looks like you did pretty quickly. So I think that's the right attitude. Don't waste so much time. And even in cases where you probably could get the whole thing out with the cutter, a lot of times I just tell my fellow, just open up the frag, and we'll be out of here in 5 minutes, so some planning helps with that. But, and then also I think if there's a fair amount of bag left and it's not hanging really back there, if you can eat as much of it, even with the frag as you can, while it's still sitting right there, that's kind of nice. Because when you have a huge lens back there, it's going to be breaking up and falling back on the retina a lot. And if you can do a lot of it in the pars plana region, that's actually nice.
Does anyone ever, oh, sorry, go on.
No, go ahead, please.
Oh, I was just going to ask, does anyone ever use 20 gauge if they know they're using a frag, or you do it this way?
Most of us
No,
don't carry.
has
most of
anyone
us
used
carry
20
20
gauge? I mean, I'm
gauge.
probably the only one who's used 20 gauge in this whole group.
Oh, we did. We all trained on it. Lots of us trained on it. No, we I mean, we don't even carry it in most of our hospitals now. I mean,
Yeah.
it's hard to hold all that supply. Hey, so here was my question for you, Austin. And so when do you see that, that initial move where the vitreous may be plugging your cannula? Did that influence what you were doing with your superior and nasal, superior nasal and superior temporal cutter? I mean, were you clearing it a little bit more before you went in with your frag? I mean, that kind of always implies to me when you see that kind of vitreous plug that you have a lot of anterior vitreous that might get dragged as you're going kind of back and forth. Did you guys do that before you went to the frag itself?
Yeah, we I didn't really show all of the pain that Dr. Lang went through, but yeah, we he made me go in and out of the cannula and made sure I really cleared that ear area, and then obviously the part we could see under direct visualization, we made sure that we cleared really well, and then I was sort of using my light pipe to support the lens underneath when it was still in the anterior segment, and I was kind of going behind that with my cutter, so I knew where I was in the plane and in the space to make sure we really cleared the anterior bit.
Yeah, the thing I like to see is when you did it, actually you went in with your MVR blade, I like to see free flow. So I like to see kind of flow, coming out of that 20 gauge MVR sclerotomy. So that means, you're not clogging vitreous, so your frag can go in. And so you saw that was a great sign. That means the pain was worth it, Ted.
In Austin's defense, the anterior segment folks literally flushed a half of a tube of viscode into the eye. Initially, they filled up the AC and then they tried to push back some vitreous, I think, with it, and ended up in the area where the inferotemporal cannula was. And it's also dispersive, which I think is different than Helon, which is cohesive and much harder to get out of the eye. And I think that's what clogged our initial cannula there.
The other thing I like to do with the frag is make sure that you have your wound large enough that you have flow on both sides, because the frag does heat up, especially on the denser lenses, and you can get a wound burn if you don't do that. So like Sunil was saying, I really like to see the flow, but I like my wound just a little bit bigger than the frag itself, so you still have flow even when the frag is in the wound.
I was being a assistant, and then I was dripping BSS on the frag throughout the
That's a good move.
I still do it. I still drip the
once again
BSS on the frag.
We actually use a 19 gauge MVR blade at Byers. I don't know if the other doctors know that, but that's what we've always used for these cases, is an actual 19 gauge, not a 20. So I think you're gonna have some leakage there, which will help.
I will plug the Bausch frag is a 23 gauge, and it's fantastic. If you guys ever get a chance to use it,
we need to get that.
Yeah, it's a great frag, and it works really nicely. And we have it at our county where we have our Bausch system, and so we just take a 23 gauge MVR and then open up a little bit, and then you can put back your 23 gauge cannula in it, and it actually will hold and seal pretty well.
Austin, what were your settings on the frag?
Sorry, Sunil, that's a frag that can't go through a cannula, the 23 gauge cannula?
No, it can't go through the
metal
cannula
on metal
because
sort of thing?
Yeah, it's metal on metal, so it'll just heat up. But you can go through your, you can go back, put your cannula back in afterwards. Sorry, Austin.
No, it's okay. So in terms of the pulses, pulse per minute that you can do with the frag, usually it's set at 1,000. I think that's the maximum that it can do, but we were having a little bit of a hard time keeping this large piece on the tip of our frag. So Dr. Lang actually suggested halving that value to 500, and we were able to hold on to the piece. But in terms of the max aspiration, I'm not actually 100% sure what it was set at. I don't know, Dr. Lang, if you know that, but
I don't remember offhand.
Yeah.
Whatever Scott put in.
Yeah, so then I was trying to use the light, aspirating very gently, as I was close to the retina, and as I was elevating it to the vitreous, I was increasing my aspiration to keep it on the tip of the frag and trying to use my second instrument or my light pipe sort of as a second instrument. And that's just another thing there. We use the plug, which I had never seen before, to help stabilize stabilize the eye. And then the last part is you want to get the rest of the capsule. So we actually just use forceps to kind of pull the whole thing off. But you can also use the cutter as well to sort of aspirate it off. And then maybe the most important part is doing a good scleral depressed exam to make sure there's no like retained lens fragments in the vitreous skirt, and obviously no tears and things like that, which we didn't have. And then we definitely need to suture this wound at the end. So we did a figure of 8 suture, which was really nice. And if you want to get like a really tight feel, you can actually kind of clamp the infusion when you're tightening it, and then unclamp it, which is a trick that Dr. Lang taught me, to make sure that you get it sealed tightly. And then, we just use the gut to close the conch over the wound. And then actually I left these 2 cannulas in while the anterior segment folks then came and did a Yamane sutured lens. And then once they were done with that part, I took out the cannulas and sutured the remaining sclerotomies as well. But he did well. I think post-op week 1, he was 20/50, which is a pretty good outcome, I think. So
That's great.
Yep.
That was a lovely job. Frags are inherently heart racing for the attending, and usually the fellow as well. Especially the one thing I'd say about the settings is realize you can change them a ton. You can go to pulse, you can have a linear, you can have it in multiple different ways. And that's probably the thing you don't realize. It's not the same as phaco, but it has a couple of similar principles of it. And you handled it well. Again, I'm sure you shortened it, and it certainly was probably 16 hours of fragging. But it is really understanding how to do that and how to use your setting. So I like pulse when I start to get these little pieces to like kind of really to try to get at it. But that was such a dense lens. No matter what setting you were using, it was going to take you time.
The thing you learn the most, Austin.
I started with that. But yeah, I'll go back to it. I think just thinking about all the different possibilities that might happen in a case and how that's going to sort of influence the instruments that you'll need. And each instrument has different kind of parameters and different ways that you can use them. And even just using the light pipe as kind of a second like instrument, chopping the lens, like there's multiple different uses for all the different tools that we have. And just knowing what's in your toolbox and when to use them ahead of time is definitely useful.
Good job. Hey, Prithvi, before we go to the next one, let me ask you a question. So we just had our
Yes,
2
sir.
amazing first years do it. Doesn't mean our 2 other first years aren't amazing, but we had these 2 first years who are fantastic. What advice, maybe we can ask all of our attendings here, do you give to your first years, like in the beginning, these first couple of months, as it seems like you're doing a new thing? How do you, is there anything our fellows that are out there should know about being prepared for something like this? Any advice you give them?
I can't say don't mess up, right? That's not the part.
The one piece of advice, Prithvi.
So I think they both said this, which is pre-op preparation. So I mean, I think coming in prepared, having either watched videos but planning like step by step what could happen, I think that's critical. I would. You may not know how it's going to work in the eye, but if you haven't done the kind of the mental planning, then it's not going to work well. So.
That's
it. For the
it.
IOL cases, definitely watch the videos. If you watch those videos over and over, you're going to know all the steps. It's going to pay off a lot for those, because the IOL cases, they're very much one step follows the other. You do this, you do that, and if you know those steps and you can do it and you're meticulous, it's going to go well. And if you just don't really know what you're doing, you're going to have a kind of a knotted mess sometimes.
Yeah, I don't typically do a lot of pre-briefings with the fellows. However, for this specific case, I remember I pulled Austin aside while she was in a room with another attending in between cases, and I did like a literal chalk talk we got on the whiteboard and we talked about all different scenarios, whether they could fake it, if they're going to have to do a CTR. And we know we're going to go in with 23, and then we're going to try to eat the lens first. It did look white and fluffy, if you didn't notice that in the beginning. So we didn't know that the little core was going to super hard rock. But we did talk about how we were going to pivot, and how the frag machine works. I had her use the device outside the eye and go through all the petal phases in a bucket of water to see what the aspiration, and then it starts to buzz and so forth. And we kind of did a dry run essentially before we were in the eye.
That's the biggest piece of advice I give is know the pedal, know the settings, especially for something new that you're doing here. And maybe in between the next case, we'll have our other attendings talk to about our second year. So let's move on to our second years. I'll introduce ours is Hung Ween Hua, who's going to start our second year lessons. Hung Ween, you got the board.
Hi, everyone. All right, let's see. Is my screen visible?
Screen is visible.
Yes.
Yep.
Great. All right, so I'm sharing a very high yield learning case and a little bit of a painful learning experience for myself, but always good to learn. And this is things that I've learned from the danger zone. So this case starts with a 75-year-old woman that had redetached in this right eye at post-op month 1. Prior, we had done a primary vitrectomy, had put an SF6 gas in the eye. And originally the break was superior, but unfortunately the patient had redetached in the right eye. The vision was 2100. There was some feathering of the cataract, and this was an optos photo of the redetachment. This was actually an area of prior laser, and you can see that there's a break there. So we decided to move forward with a buccal vitrectomy. And originally, as you can guess from the title of the PowerPoint, there's music, but since this is in public, I don't want to get in trouble with copyright. I would sing it for you guys, but I might hurt your ears. So you're going to have to just imagine the danger zone playing right here.
My God, Christy's about to sing.
If you want to take a step back and talk to us a little bit about, because you did the first case and then this case as well, what's your approach for someone who detaches? Why did you decide to do a buckle, or why did we decide to do a buckle on this one? What other things were you sort of thinking about?
Sure, absolutely. So when someone redetaches, I will usually automatically default, if they didn't have a buckle already, to put a buckle on to reinforce the vitreous base. And then I want to look to see if there's any PVR. Luckily, with the optos photo and when we examined the patient, it didn't look like there was any. So kind of preoperatively planning, do I need a stain? Am I going to have to peel anything? Am I going to have to retinectomize? This looked like mostly like a redetachment from an area of a prior break that we had laser. And so we were hoping just for to add the primary to add on a buckle, and then also to make sure that we get rid of all of it the second time around. All right, so first steps first, even though we've done a vitrectomy already, we want to look for any residual vitreous. So I stained with Kenalog here. And then here's the buckle. When we looked in, the buckle had looked a little too low, so we're tightening here. And so here, this is where I really, really hate myself. And at very slow. It literally was that I had eaten retina. And so it's very, very sad. But, oops, sorry about that. I ruined the ending.
And so tell us a little bit about what happened and why you think that happened.
Right, exactly. So it's a post-vit eye. There's no vitreous. Retina is very pretty bullous, moving pretty freely and pretty quickly. And I was probably vacuuming too quickly, close to the break, and the patient's phakic as well. So I was probably wanting to stay away from the lens, yet far enough from the retina, and I didn't hit that sweet spot. Another thing that should consider and think about is where the break is and where the infusion is pointing. If the infusion is pointing directly into the break and causing the retina to be more bullous here. So a lot of things to think about. And while I was hating myself at the very same time, you have to think about what are your next moves? How do I prevent this from becoming worse? So think IOP to 60, grab the cautery, and start diathermizing right away to prevent any heme from getting under the retina as well.
So let me ask two things. One, thanks for showing this case. Not easy to show something where things didn't go ideally. So I'm going to flip the question to Kat. When you're walking fellow, all right, obviously there's a lot going through Hung Nguyen's mind right now. We've all been there. We've all sat in the chair. We've all had the attendant give us the death stare through the side scope. What do you tell fellows at this point? What do you like? How do we as second years who think we know everything and maybe sometimes still can do things a little bit too aggressively that can make things a little bit worse? So tell us what you were thinking at this point.
Yeah, I mean, I'm sitting there. I think Hung Nguyen, we've had a really long day on this day. I think it was like our last case, and we had just done a bunch of complex PVRDs back to back, and then this was going to be our easy one to sort of finish out. So, I mean, I was kind of feeling, I think, like you were probably just kind of ready to be on the last case. I think there's two things to address as you're sort of teaching fellows and a complication happens like this. The first thing is, I'm thinking in my head, I'm going to talk to Hung Nguyen about why this happened, about sort of ways to prevent that. But now is not the time to do that. I think, it's good to start training your brain to know that mistakes are going to happen. That's just part of being a retina surgeon. And you got to make sure that you're ready to go to prevent that complication from becoming something worse. So as much as, it sucks that this happened, I'm immediately looking around because it's early in the case to make sure that the diathermy is actually open, because sometimes it's not open that early in the case, and making sure that she's going right to 60. So I'm literally saying out loud, 60, 60, do we have cautery, and making sure that that's present. And then I'll make a point of sort of decompressing with Hung Nguyen afterwards. I don't think it's beneficial to sort of have that conversation in too much detail during the case. I think it's more important to sort of get control of the eye. I don't know if anyone else has a different approach.
No, what I would say is the most important thing is, Hung Nguyen, don't say you're sorry right now. Hit the pedal to 60.
Right.
Just we'll talk about it later. It's going to happen. So I appreciate you showing it because it's not easy to do. So as you were saying, Hung Nguyen, do you think this was on the pedal too quick and port position of position of your cutter as too close to the retina?
Yeah.
So your takeaway from this then was?
My takeaway for me is to slow down, and even in a phakic eye, and especially a post-fit eye, slamming on the pedal doesn't mean that you, especially as I'm trying to get rid of the Kenalog, slamming on the pedal doesn't mean the Kenalog will go away faster, and to do things safely and think of what will do the least harm and what position is safest in the eye in a post-fit attachment.
You said it well. Pressing harder on the pedal doesn't make the case go faster. Right?
The other thing that Kat had mentioned, thinking about where the infusion is pointing, often we just put the infusion in and tape it down however looks convenient or however we always do it. But in an RD, really thinking about which way you're taping it so that you're not blowing directly into a break, I think helps prevent that too.
And I think doing the things that you did was preventing another problem, right? So you make a mistake, you make a problem. It's the next thing you do that really kind of tells us how you are. So this is great because we already know what kind of surgeon you are. All right, you made a mistake. I'm on it. Let me fix it.
I'd also say that that's the difference between a year ago and now, right? So I think that if this is a year ago and this happened, I mean, you could be not you, because you're awesome, but one could be paralyzed with fear and the rest of the case just isn't going to progress. And here, yes, Kat was there to reinforce with your staff, we need this, but you probably have, kind of iterated that in your head already, which is the difference. I mean, I think that's what a year of fellowship will do for you, is that these types of things, will happen. You kind of know the next steps, and it's not the, oh my God, I'm so sorry. That's not the first words out of your mouth. You're just okay, I got to move this along. And I think that's the difference.
In fact, those words shouldn't come out of your mouth when the patient
Right.
Ever.
Ever. Never say it.
Don't say sorry. Don't say shoot.
No.
Don't say other words.
One question, Hung Nguyen, in these eyes that you post vit, it's a good vitrectomy. Sometimes you could just go to perfluoron immediately. Would that have made a difference? Your first move before steroid could have been, PFO into the eye. Did you consider that?
Yeah, absolutely. I think it could have stabilized the retina better and made the retina less bullous. I think we hadn't considered it earlier because we wanted to stay in and see if there was any residual, but knowing that it was good vitrectomy, or putting perfluoron in earlier would have been a good move.
Yeah, I second with Prithvi. I think you did. I think you did the right thing by putting the triamcinolone in and making sure you don't have residual hyaloid attached posteriorly. But once you've kind of realized that there's no posterior hyaloid left, and that's not the cause of the redetachment, I think the next step would be to put the PFO if you're going to be using PFO. The second thing is, I think when you're doing an RD case, if you notice that suddenly the retina is getting much more bullous, then you should take a moment to go, why is it getting more bullous? And is it just because there's more fluid going through the break? And, maybe in that case, you just want to do a little bit of vitrectomizing right over where the break is and try to actually make it less bullous and that sort of thing. You also want to check your infusion to make sure that somehow the infusion isn't now under the retina, which can sometimes happen. So if the retina starts acting funny, if you notice that ahead of time, you can maybe take some corrective actions before you have a problem.
Right. Yeah, all great points.
Great job, Hung-Ween. Keep going.
So as I'm diathermizing my mistakes away, we now put in the PFO to help stabilize the retina, and continue to shave, depress, make sure all of that vitreous is off. And we're going to the area of the original break. Thought that we overcompensated the second time, so we loosened the buckle a little bit here. Placed more PFO.
Hung-Ween, that's a beautiful drainage retinotomy you created. That was
Yeah.
beautiful. Perfect.
Perfect.
So
She was just thinking ahead. She was thinking ahead. That's what she was doing.
She
You're
was
all
being a
slow.
good second year, thinking of the next step. She was just like, what's going to make this case easier? I know.
Right.
Maybe drink through.
I thought, how do I make my air fluid exchange efficient? Wish that was true. And so here we're doing the air fluid exchange, making sure that, the original or the second causative break and the break that I made are dry. And we're closing here. And I'm thanking Dr. Talcott for her infinite patience. This is one of my weird favorite parts of a buckle.
Mhm.
And that's the close.
It's my favorite part because I usually walk out of the room at that point.
So fortunately, there's a happy ending. Post at month 4, patient had quite a cataract, 3+ NSC, but pinhole to 20/50, and they're still attached. So takeaway lessons, what I've learned from this case. So just to set the context here, we were actually on a roll. I was, April of first year fellowship, and this was the 6th case of the day that I had done with Dr. Talcott, and we had managed to stay in the ASC OR and weren't bumped to our main hospital OR 26. So I was feeling myself. I was like, yeah, I'm doing great, having a great day with Dr. Talcott. But you have to kind of slow down, beware of the mental fatigue, and just treat your last case as your first case, even though you can be really tired. We talked about being on gentle vacuum, using PFO, paying attention to where the infusion is. Most importantly, when you make a mistake, take a deep breath and think of your next corrective actions in order to not make your mistake worse and to do what's best for the patient and to recover from your mistakes. And I am always thankful to my amazing tendings that don't kick me out of the chair, even though things happen in the OR. And I hope that I don't worsen their already existent hypertension. So,
I don't have hypertension.
not yours.
I have hypertension.
I don't.
I have hypertension.
I know you don't.
Chronically.
I just
Hung-Ween,
haven't
I
measured
look
my high blood pressure.
Hung-Ween, I look forward to the day when you are the attending. So what you said and how you said it, I think your future fellows are going to benefit from your wisdom. So that was great. Nice job.
Thank you.
Nice job.
All right, Prithvi, last case,
Our
bro.
last presenter is one of our second-year fellows. So Suzanne Mikulak is second-year retina fellow here at Stanford. She came to us from Duke, where she did her residency. and always has excellent videos to share with us. And Steve and Ted, take it away.
Carolyn, I think.
Oh, Carolyn.
I think you were the
Carolyn.
attendant on this case, right, Carolyn?
I am not aware of that, but probably
Oh.
if it's
It was Dr. Nirala.
Oh,
Even
okay.
better. All right. So this
The
was done
junior
at
Carolyn.
our Santa Clara Valley site, which has lots of good fun.
Okay, I'll start by saying those were all three amazing cases, tough acts to follow. So this is not, I'll say, one of my most beautiful cases. I tried to pick a case. I think the case went well overall, but one where I didn't do everything perfectly to kind of illustrate things that didn't go well the first time, that I think I made adjustments, and then they went well later on in the case, which is kind of what I want to talk about and what I've learned second year in comparison to first year. All right, so it's a 6-year-old guy with proliferative diabetic retinopathy. He presented earlier this year with decreased vision in both eyes, had vitreous hemorrhage in both eyes, and tractional retinal detachments in both. He already had a TRD repair in the left eye about 3 months ago, which had gone well. He ended up with 20/40 vision. So then we went on to this eye, which had 21/50. He had a little bit of a cataract, otherwise anterior segment exam was not remarkable. And then on the DFE, he had a little bit of vit-heme, which made the view somewhat hazy. A TRD involving the superior macula, a macular hole, and this kind of interesting looking localized pocket of subretinal fluid inferior-temporally that had been stable for a while. I know that it went a little fast. You guys saw those OCTs. So the schisis, the mac hole, and then inferiorly going that little pocket of fluid inferior-temporally. So this is the first thing I want to talk about. I think I got this wrong a lot first year. It was that I didn't realize that the eye wasn't in primary position when I was placing my trocars. So now I always check to make sure it's in primary position. And if it's not, I'll hold it down with a Q-tip to make sure that the trocars are where I want them to be later in the case. Because I've also made the mistake when I know there's going to be peeling later on, that my trocar is too much towards the horizontal. So either too much at 3 or 9, depending on which eye it is. And then it's really hard to peel. So here, even though he was looking a little up, I made sure to hold it down before putting in the trocars. I don't know if anyone else has anything to add on that or trocar placement, but I think that was one of my main pearls of first year was if the trocars aren't in a good position, the rest of the case is going to be very challenging.
I think you said it well. A lot of times it's interesting. I have I would say 120 degrees, or I try to put it in like a number. And I always am impressed how protractors weren't used by most of my fellows, and 120 degrees turns into 64 degrees or something else. So yeah, I think it really is getting into primary. So that's a great lesson. And I think a good thing for even our first years to kind of hear is trocar placement is so important. It is the most, obviously it makes sense, but it is so important. And obviously the anterior posterior positioning as well.
We saw some COBRA cases last year where the eye was moved and then the trocar cannula was brought in and it skewers the crystalline lens. So you think you're just putting it in, but you can be really turned over to the side and going in goes into the lens, and that changes your case step 1.
So got the trocars in here. I was happy with their placement. Then we're just doing 360 AP traction segmentation, which we usually use to start all of our TRD cases because the hyaloid is usually lifted in the mid periphery. Then once we did that, we reassessed and made sure that the pathology that was going on is the same as what we expected from the photos in the preoperative exam the week before. Usually we'll give patients preoperative Avastin the week before and take a look to make sure everything's stable, but it was the same as the pictures here.
How far before the case are you giving Avastin or anti-VEGF before your TRDs?
At least at the Valley, we always give it 1 week ahead of time or I guess 6 days, because that's when our clinic is on Thursday or is on Wednesday. But I think some people give it in a range from 2 days to a week is what I've heard most commonly.
I mean, there's not great data on it, but there's some data that less than 3 days isn't really effective, and that 3 to 5 is probably not as good as greater than 5. So I tend to do a week before.
Great.
And then we were starting to lift the PVD. We were going to do it with forceps to be a little gentler and get more traction than with aspiration. This is again a part of the video of me failing. I was trying to do another wide angle lens. And I think I wasn't reaching deep enough. So then decided to switch to the contact lens, which I think earlier on in my first year, I think I spent about 1.5 minutes struggling with that. I think earlier on, I probably would have spent closer to 5 minutes before deciding or like asking to try a different technique. So then we tried the contact lens where I could see a lot better. I felt I could see a lot better and was able to grab deeper, and then got the PVD within about 30 seconds, which was much more satisfying.
Yeah, I think it's a hard
Yes.
thing to learn, like sort of where to grab for these and how much traction to pull, because you actually need to have a really good grasp on it to kind of lift it up. And then, you know, the other pearl, I think, as you're sort of a second year fellow, is sort of where to look as you're pulling. Like, obviously, you want to make sure you're not grabbing the nerve, grabbing retina. But then as soon as I get a good grasp, I actually want to see what's coming up with my gel, you know? So it's that transition of looking where your instrument is to actually looking at the tissue around it, because that's where you sort of run the risk of causing damage by this stuff.
Carolyn Penn, you manage so many of these TRDs for us. Do you find the contact lens is something that's helpful or not for a starting fellow for these maneuvers?
Yeah, so I have the fellows do it under contact lens. Obviously, it does take a little extra time just to get them oriented under the contact lens. So I make sure they see both instruments before they start pulling, but I think they get better stereo view, higher mag, and they're a little bit more confident that they're grabbing enough. Like Kat said, if it's too superficial, the adhesion of that fibrosis to the nerve, you're not gonna get it off, and you're just like picking at it and causing blood everywhere, and it's just a big old mess. So I actually have all the fellows, when they do these using the PVD, do it under the contact lens. Very rarely I'll use the green lens. I've used it a little bit more recently, but I like the contact lens. I think it's just the best view.
Yes, I guess the trade-off is just that it's harder to see in the periphery what you're pulling, as Dr. Talcott is saying. But I agree, it's much easier. I like the contact lens.
The first years I just tell them pull straight up, and then like they stop when I tell them to stop. But again, this is more from the feel. And once they can consistently get it up, then I start pointing out what I'm looking at, like Kat mentioned, which is really not at the nerve, not where they're pulling, but where the hyaloid is down and where there are points of traction. And I'm pointing out all the different pegs, where there's tenting, where there's bridges, so they can go back in with the cutter and then start segmenting.
Yeah, so to that point, then we went to segmentation to see where the bridges were, because the main area of traction seemed to be superiorly on the arcade. So this was segmenting the nasal bridge there in that area of traction. And then we saw this nice thick band of hyaloid that I tried to peel. And I preferred to peel with my right hand always. So I was trying here to do it, but it wasn't coming. So then with the left hand and the cutter instead, it came very easily because we were able to approach it from the posterior pole where the hyaloid was already up. Which I think was a better way to approach it.
That's satisfying right there.
And then we got lucky in this case. I think it was still a pretty early TRD. There were a lot of bridges that were more easily identifiable. So then we had removed most of the traction from there. So then we went over to this kind of pocket of fluid. In this case, the view is really poor. And I think this is another thing that I've learned most going from first to second year, that if your view is really bad, always try now to figure out why. I think like early on in my first year, I wasn't quite sure what a good view was versus a bad view. And now I realize it's almost always possible to get a good view. So if it looks like this, then I'll always kind of take out the resight and try to figure out what's going on. Does the cornea look really bad? Has the lens gotten cloudy? Is there an air bubble in the way? Do I need more viscoat? So in this case, it was just, we needed more viscoat. And then you can see afterwards, the view is much better. I've been told a million times, visualization is everything. So here we identified a hole after we kind of cut right over it and we're trying to trim. So we diaphragm the hole. We initially tried to peel the hyaloid off of this area and it was very firmly attached. So then we decided to just trim over it. And then lastly, turn our attention to the macular hole. Here again, I think pearls I've learned, and I'm still learning. I think all of this is just like an ongoing learning process, of course. My fellowship is 2 years, as Dr. Ruth and Jay always says. I again always like to start inferior temporally for all my peels. And I think as I get more into second year and learn more, I'm starting to try different places, like where there's drier, where it looks easier to peel and not just where it's comfortable. So here I did that. And it ended up not being a great area to start because this is where there was a little bit of subretinal fluid from that pocket. I made a bit of a deep grab, which was fine. There was no heme, but then I started somewhere else and it came up much more easily. I decided to show this video in kind of more real time too, because I found, at least for me, and when I watch the attendings too, a lot of times it will take a few grabs before you get a really nice flap, which I think I didn't realize early on when I saw a lot of the videos or things online.
And, we were talking about this in our surgical rounds last week, is that, it's okay as a fellow, to have that like almost grab, like you kind of come close, you make that initial connection with the forceps, but you don't have to, go at that moment. You can, sometimes take that practice grab before you get the real grab, and that's okay. I mean, you have to learn what it feels like to get that close. So that's perfectly fine with me.
Do you think, Suze, do you think that was all ILM, or do you think there was ERM here?
I mean, I'm
just from the feel of it.
Looked like there was a little bit of ERM.
So, and the reason I ask is more of, it looked like in the beginning, your highlight was pretty adherent. Was there a need, do you think, to peel the ILM in this scenario if this was tractional to begin with, right? So if some of this was all tractional and it was from the stent hyaloid, could you have, if there was no ERM, or, could you have just left it?
Yeah, I mean,
and just put a gas bubble in and see if it settles.
If you had been, I mean, I think it's hard in these cases to be 100% sure that you've gotten all the hyaloid off, and peeling the ILM, you can ensure you've gotten all the hyaloid off too. Although I think the hole was pretty small. If all the traction was relieved, certainly there was a good chance you could have gotten away with it. So I think if the view had gotten really bad, or there was a lot of bleeding, or another reason why we had to end the surgery early, probably would have skipped this part. But I think the earlier steps had gone more easily than expected, so we had time. And the
I think you said it well, right? If the view is good, go for it, right? You always want to wait out of the case, right? If you do this too early and you haven't accomplished all your other things, then you're setting yourself up for trouble. So, but that's great. That's a really good teaching point.
Yeah, we just wanted to make sure the hyaloid was up, especially in the setting of the RRD component as well. So that was another motive for peeling.
Excellent.
So Neil, I think that there probably isn't an ERM here, at least at this point, because you're seeing kind of pretty good staining of the ILM. And if there was ERM, it wouldn't be staining. But maybe there was before and it came off with the hyaloid when she peeled the hyaloid. Sometimes it's really hard to tell until you stain, and then you can see if you put that ICG in there, or brilliant blue, and there's little patchy areas of staining, but most of it's not staining, then there's probably a significant ERM still there.
Yeah, just based on the look of it as it was coming across, it looked a little bit fibrotic. That's all. That's why I was asking. It just looked like a thicker, if you will, ILM peel. So, and then regardless, it looks like it was mainly ILM.
Yeah, it makes you wonder if maybe the ILM has some inherent fibrosis itself or something, or that there's a thickened ILM, because once again, it shouldn't stain if it's an ERM. It didn't come off kind of like your typical macular hole case where there's absolutely no ERM and it comes off in this beautiful, delicate sheath.
Yes, and then this is the clip that I would normally show for the peeling part.
Man, you're so fast. Wow, you're such a great second year.
Right. So at this point in the case, we decided to drain from our hole that we had and go to air. So we did that and then lasered around the hole first before the fluid reaccumulated. And then I also wanted to show this part. I think something that I've learned first year. You see, this is not a great PRP for that one section there. It was all running together. And I've learned, at least for me, usually our interval is set on like 150 or 100. And for me, still that's too fast. So I usually like to change it to 300. It's much more relaxing for me. And then that doesn't happen. And then they have nice smooth rows that look much better. So that's the other thing I've learned, kind of similar to the view, and just trying a different tool if whatever isn't working in my hands, is changing the settings too if it's not working for me. But the patient's now 2 weeks out, still attached under gas. We put in C3F8. So don't have long-term outcomes yet, but everything's looking good at this point.
Anytime you try to
I think your
peel,
point about the laser is a good one. I mean, as attendings, we often will see fellows have it on fast repeat, and they're just like hitting it, and none of them are actually, every third shot is actually showing a burn, and like, you've gone over the same area 5 times now. Maybe if you slow down, it'll actually be more efficient, So I think that's a good point, that, if you can do it real fast and you're getting nice, good burns and everything, that's great. If you're not, slow it down.
Yeah,
And I'll say this is, oh, go ahead. No, I was going to say, I was just going to say that as a second year, you're allowed to pick any settings, because there's no greater hell than watching a first year laser. So as a second year, go for it, do whatever you want. But first year laser offhand, that is going to be my personal hell. That one every 16-second laser burn, that's my favorite part of fellowship.
oh man,
This is when you actually get up, Sunil, and actually dictate or whatever.
I try to leave at that point, yes.
One of my best teaching points the first year was when Dr. Stanislaw had me do an entire PRP on single shot. My calf was really sore afterwards.
That's like running laps.
Was that like a punishment, Steve? Was that what you were trying to do? It's like say, this is what you get. You have to press the pedal down. Ouch.
I think I was doing a lot of that first one. So it's
that will stop that right away, right? When they have to make the whole burn each time, and so
I'd like it. I may adopt it.
I'm going to use that one.
Mm-hmm.
That was really, really very good. And this is complex in a different way. And I think as a first year, you may not have done as much of this case as you accomplished to get through at this point. I think that's really good.
Yes, I'm very lucky and fortunate to have all the wonderful teaching and such patient attendings. Thank you all. Very lucky.
So Prithvi, how about what advice, let's ask what advice we should be giving our second years in July, August, September right now to kind of take off and really kind of end their, it's hard to believe, but begin their second year and maybe get to that sweet spot of fellowship.
Yeah, let's turn it over to our mentors here. Steve, you've been doing this a while.
Graduating from first year to second year? Is that kind of the question?
Yeah, what do you tell your second years at this point? Like, how they make that adjustment, or what's the key for them at this point in your mind? I'll give you mine. I mean, I'll tell it. It's actually something John Sears once told me that he did. What was he used to dictate his attendings cases for them, and I say that in jest, but actually being able to tell me what's going to happen with the whole case before we even have gone in there. Just walk me through it, even in 30-second bursts right before we walk in, as we're prepping and such. Here's what's going to happen. I'm going to do this, 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 and this. I think having that kind of mental plan gives you an idea of like what you're trying to accomplish. And for me, then it's, okay, what instrument do I want to make sure I have for each of these steps? So that's kind of like how I think that transition from first year is I'm really, really relying on the attending next to me. And on the second year is I've seen 15 other people do it or 6 other people do it. This is how I think we should do it. And maybe taking a little into consideration of how we like to do it as well.
I didn't meet him.
I agree that, I think it's more important for the second years to have that preparation and to go through what they're going to do, because they're the ones more, if it's a simple case, the first years are going to do the whole case, right? But we're talking about more complex cases, and the first years are going to be watching more, but the second year is going to be doing the whole case. And so definitely I want them to know what their plan is, what they're doing. So I think that's a great point, Sunil. I kind of, you know, don't always see a huge difference sometimes between the first year and second. They're kind of working in, I mean, they come for a few weeks with us, and then, you know, so it's really individual, and I try to, you know, help each individual fellow, you know, live up to what they can do best and work with them at their level. And so I don't always see a difference between the first year and second year, and like it's not some sudden change that they suddenly are now amazing surgeons where before they were lousy. But certainly I do feel more relieved sometimes when I have a busy day with complex cases and I see it's going to be a second year fellow with me.
I think I noticed a difference between first and second year fellows in that the second year fellows ask me more questions. They've seen it, they've done it, and then now they're scared because they're going off into the real world on their own. And I think couples, like last month, it was mentally exhausting. Physically, it was easy. I was just sitting there watching him operate, but everything he was asking me, and I had to, this is what I tell the first and second year residents when you do surgery, is to be intentional. Don't just go through the motions because you think those are the steps you're supposed to do. Like, think about each step and why you're doing each of those steps. And then that way you minimize unnecessary movements, unnecessary complications. But he was like putting me to the test and making me answer why I was telling him do X, Y, and Z, or why I prefer this method over another method. And so I think second year, yeah, sometimes they're like coming in, especially I get them at the beginning of second year and the end of second year. You can't really tell, you know, if they're beginning or end, they're all great, but the number of questions I get by the end of the year is definitely more. And that makes me happy.
Yeah, I turn it around and say, why do you think we do it? So I don't have to answer any questions.
What do you think?
I think the big one
Very
is,
nice.
Tell me, buddy.
I think this was a great session, and we saw things that went well and things that didn't go well, which is, you know, that's part of being a surgeon. And I think we saw some very thoughtful ways to get out of trouble as well. So first off, round of applause to all the fellows that presented today, because it takes a lot to show you know, things that just aren't just perfect, but at the end of the day, I think all the decision making got the patient the best outcome that they needed. Thanks to the mentors here today who took the time to not only guide them through the surgery, but share their pearls of wisdom along the way. And Sunil, what are we doing in a couple of weeks?
I'm happy to announce that since Academy is live in Chicago, we are doing COBRA Live on September 30th. I think we're going to show a little thing on that right here in just a second. It is on Friday night. It's going to be a fantastic event at the Wit Chicago Hotel. We will have cocktails, some made just for Prithvi, which will be exciting. I think he loves the Shirley Temple.
Lots of umbrellas.
Lots of umbrellas will be fantastic. But great case discussion, hopefully a lively group of attendees. Certainly there's going to be a lively panel because we're going to have the panelists, some of the panelists you've met here, and I think it should be a really great time. So please come and join us. Super chill, super relaxed. It's going to be a lot of fun. And again, a great opportunity to meet friends and learn about some retina surgery and discuss it, things we all like to do.
Yeah, thanks again to Bausch & Lomb for their support, and also for our friends at iVista for helping to put this together. And I know we have a bunch of fellows on board tonight, but also some folks that are entering the field of retina. So we wanted to show you that this is the coolest field in all of ophthalmology. So welcome to the club, and we look forward to having you as friends and colleagues in the years to come.
And we will have another COBRA session back in October. I don't think we have set a date yet, but we will forward that date to everyone here. And we look forward to doing this again. Thank you all. Have a great night.
I wanted to point out.
Bye, guys.
Good night.
What do you want to point out, Hungween? You get the last word.
Don't yet. Let me have the last word. It was all women that presented tonight. Go women in retina.
That's well said.
Night.
Night.
Yeah, good night.
Bye.
Prithvi, you're going to have to be this entertaining in a month in live. Do you think you can do